Welcome to the Saunders Pyramid to Success Fluids and Electrolytes Review. Fluids and electrolytes is a content area that most students find complex and difficult to understand. The National Council Licensure Examination, NCLEX, will not ask specific questions about body fluid transport systems or pathophysiology. However, you should review this information because it provides a foundation for understanding other concepts. Refer to Chapter 9 of the Saunders Comprehensive Review for the NCLEX examination for a self-paced review of this content. In this audio, some basic concepts are reviewed, followed by some commonly used intravenous solutions. Finally, 4 imbalances are reviewed: fluid volume deficit, fluid volume excess, hypokalemia, and hyperkalemia. For information about sodium, calcium, magnesium, and phosphorus imbalances, refer to Chapter 9 of the Saunders Comprehensive Review for the NCLEX examination for a self-paced review. To begin, recall that there are 3 primary body fluid compartments. These include the intravascular compartment, the intracellular compartment, and the extracellular compartment. The intravascular compartment refers to fluid inside a blood vessel. The intracellular compartment refers to all fluid inside the cell, and most body fluids are located inside the cell. The extracellular compartment is the fluid outside the cell. This compartment includes the interstitial fluid, which is fluid between cells. This is sometimes called the third space. Let's review some concepts that are basic, yet important to remember and relate to body fluids. Body fluids transport nutrients to the cells and carry waste products from the cells. The total body fluid amounts to about 60% of body weight in the adult, 55% in the older adult, and 80% in the infant. Therefore, 2 important points to remember are: 1. Infants and older adults are at a higher risk for fluid-related problems than are younger adults. And 2. Children have a greater proportion of body water than do adults, and older adults have the least proportion of body water. So, infants and older adults need to be monitored closely for fluid imbalances. Fluids and electrolytes enter the body via ingested fluids and foods. Fluids leave the body via the skin, lungs, kidneys, and bowels. The usual daily loss is 500 milliliters via the skin, 350 milliliters via the lungs, 1,500 milliliters via the kidneys, and 150 milliliters via the bowels. Additional concepts to understand include third spacing and edema. Third spacing is the accumulation of trapped extracellular fluid in an actual or potential body space. It occurs as a result of disease such as malignancy or trauma such as a burn injury. This trapped fluid represents a fluid loss and is unavailable for normal physiological processes. In other words, it is useless and potentially harmful. Fluid can be trapped in body spaces such as the pericardial, pleural, or peritoneal spaces, joint cavities, the abdomen or the bowel, or within soft tissues. It is important to remember that assessing the fluid loss caused by third spacing is difficult. The loss might not be reflected in weight changes or intake and output records, and may not become apparent until after organ malfunction occurs. Edema is an excess accumulation of fluid in the interstitial space. Localized edema occurs as a result of traumatic injury from accidents, surgery, local inflammatory processes, or burns. Generalized edema, also known as anasarca, is an excessive accumulation of fluid in the interstitial spaces throughout the body, and occurs as a result of conditions such as cardiac, renal, or liver failure. The amount of edema can be assessed by using the fingers and pressing on the skin. When the indentation of the finger remains in the skin, it is termed pitting edema, and is an indication of excess fluid in the interstitial space. For additional information on the scale used to assess pitting edema, refer to Chapter 34 of the Saunders Comprehensive Review for the NCLEX examination. Fluid and electrolyte imbalances manifest as either a deficit or excess. 4 pyramid points that will assist you include the following. 1. In a deficit, most but not all of the assessment findings will be depressed or decreased. Conversely, in an excess, most but not all of the assessment findings will be increased. 2. Assess the client in a systematic manner. Assess cardiovascular, respiratory, neuromuscular, integumentary, gastrointestinal, and renal status. 3. Treatment is focused on replacing the fluid or electrolyte that is deficient, inhibiting, blocking, or promoting excretion of excess fluids or electrolytes. And 4. Use a cardiac monitor to monitor for dysrhythmias. Also monitor laboratory values, specifically the values related to the client's condition. Next, let's review the 3 main types of IV solutions, commonly used IV solutions and their purpose, and some important points to remember. The 3 main types of solutions are isotonic, hypotonic, and hypertonic. Isotonic solutions do not cause a shift in fluid in or out of the cell. These types of solutions can be used as volume expanders, such as in clients with burn injuries requiring fluid resuscitation. Hypotonic solutions cause a shift in fluid from outside of the cell to inside of the cell. These types of solutions can be used in clients who have fluid volume deficits. They should not be used in clients with fluid volume overload, such as in congestive heart failure. Hypertonic solutions cause a shift in fluid from inside the cell to outside the cell. These types of solutions can be used in clients who have fluid volume overload. They should not be used in clients with fluid volume deficits, such as dehydration. Next, let's review some commonly used IV solutions. First, 0.9% saline, also known as normal saline solution, is an isotonic solution. It is used to treat extracellular fluid deficits in clients with low serum levels of sodium or chloride and clients with metabolic acid-base imbalances. It is also the solution used before or after the infusion of blood products. Second, lactated Ringer's solution is also an isotonic solution. This solution is used for extracellular fluid deficits such as fluid loss from burns, bleeding, and dehydration, and for extracellular fluid deficits from loss of bile or diarrhea. A third commonly used IV solution is 5% dextrose in water, also known as D5W. This solution is isotonic at the time of administration. However, within a short time after administration, the dextrose is metabolized and the solution can become hypotonic. This solution replaces total body water deficits. However, it is not used alone to expand extracellular fluid volume because dilution of electrolytes can occur. There are 5 important pyramid points to keep in mind when administering intravenous fluids. 1. Caution is needed when administering IV fluids to any client, but be particularly careful with older clients, infants, and young children. These clients are at higher risk for alterations. 2. When an IV solution is prescribed, think about the client's diagnosis and consider the pathophysiology with the disorder. You want to be cautious with clients with heart, lung, brain, and renal disorders because of the risk of fluid overload. 3. If the client is likely to retain fluids, such as in renal failure or heart failure, sodium chloride or normal saline should not be administered unless specifically prescribed. However, if it is prescribed, verify the prescription with the physician. 4. If your client has diabetes, dextrose solutions should not be administered unless specifically prescribed. However, if they are prescribed, verify the prescription with the physician. 5. Solutions containing potassium should not be administered to a client with renal impairment. Potassium is excreted via the kidneys, and life-threatening hyperkalemia can occur if the client is unable to excrete the potassium. Next, let's review some pyramid points related to some common fluid and electrolyte imbalances. First, fluid volume deficit. When you read or hear the words fluid volume deficit, Think about fluid loss or dehydration. In this condition, treatment is aimed at restoring fluid volume, replacing electrolytes as needed, and eliminating the cause of the fluid volume deficit. There are several causes of fluid volume deficit, and it may be difficult to recall all of them. Remember that any condition that causes a loss of body fluids can result in a fluid volume deficit. So think about it. Can vomiting and/or diarrhea cause a fluid volume deficit? Yes, they can. Can prolonged fevers and excessive perspiration cause a fluid volume deficit? Yes, they can. Can diabetes insipidus cause a fluid volume deficit? Yes, it can. Can chronic illness or malnutrition cause a fluid volume deficit? Yes, they can. What signs and symptoms would you note in a client with a fluid volume deficit? Think about the pathophysiology associated with the deficit. Most signs will be depressed or decreased. For example, decreased blood pressure, diminished peripheral pulses, decreased central nervous system activity, decreased urinary output, decreased gastrointestinal motility, decreased body weight, flat neck veins, and skeletal muscle weakness will occur. The pulse rate, which will be thready, and the respiratory rate will be increased in an attempt to compensate. Depending on the type of dehydration, you might note hyperactive deep tendon reflexes and pitting edema. Other significant findings include dry skin, dry mouth, thirst, poor skin turgor, and skin tenting. Most laboratory values are increased, such as the hematocrit, blood urea nitrogen, serum sodium, urine-specific gravity, and serum osmolality. What about fluid volume excess? When you read or hear the words fluid volume excess, think about overhydration or fluid overload. The goal of treatment is also to restore fluid balance, correct electrolyte imbalances if present, and eliminate or control the underlying cause of the overload. There are several causes of fluid volume excess, and it can be difficult to recall all of them. Remember that any condition that causes fluid retention or overload can result in a fluid volume excess. So think about it. Can renal failure cause a fluid volume excess? Yes, it can. Can excessive sodium ingestion cause a fluid volume excess? Yes, it can. Can congestive heart failure cause a fluid volume excess? Yes, it can. What signs and symptoms would you note in a client with a fluid volume excess? Think about the pathophysiology associated with an excess. Many signs will be the opposite of those noted in a fluid volume deficit and will reflect an increase. For example, an elevated blood pressure, distended neck veins, bounding pulses and increased pulse rate, increased respiratory rate, crackles on lung auscultation and dyspnea, increased urine output if the kidneys are able to compensate for the excess, increased gastrointestinal motility, and increased body weight will occur. Other significant findings include an altered level of consciousness, complaint of a headache, pitting edema, cool pale skin, and skeletal muscle weakness. Most laboratory values are decreased, such as the hematocrit, blood urea nitrogen, serum sodium, urine-specific gravity, and serum osmolality. Now for a quick review and some self-check questions. For which fluid imbalance would you monitor in a client who is vomiting, deficit or excess? Correct, deficit. For which fluid imbalance would you monitor in a client who has congestive heart failure, deficit or excess? Correct, excess. For which fluid imbalance would you monitor in a client who has diarrhea, deficit or excess? Correct, deficit. For which imbalance would you monitor in a client who has diabetes insipidus, deficit or excess? Correct, deficit. For which fluid imbalance would you monitor in a client who experienced excessive sodium ingestion, deficit or excess? Correct, excess. For which fluid imbalance would you expect to note bounding pulses, deficit or excess? Correct, excess. For which fluid imbalance would you expect to note decreased urinary output, deficit or excess? Correct, deficit. For which fluid imbalance would you expect to note dry skin and poor skin turgor, deficit or excess? Correct, deficit. For which fluid imbalance would you expect to note thirst, deficit or excess? Correct, deficit. For which fluid imbalance would you expect to note an increased hematocrit level, deficit or excess? Correct, deficit. Well done. Potassium imbalances are serious imbalances that can be life-threatening because every body system is affected. The normal potassium level is 3.5 to 5.1 milliequivalents per liter. Hypokalemia occurs when the potassium level is lower than 3.5 milliequivalents per liter. In addition, hyperkalemia occurs when the potassium level exceeds 5.1 milliequivalents per liter. Let's review hypokalemia first. The causes of hypokalemia relate to conditions that will cause the excess excretion of potassium or the movement of extracellular fluid to the intracellular compartment. Some common causes include use of medications such as diuretics or corticosteroids, vomiting, diarrhea, excessive gastrointestinal wound drainage, prolonged nasogastric suctioning, inadequate potassium intake, and some forms of renal disease that impair reabsorption of potassium. What assessment findings will you note? In hypokalemia, many of your findings will be depressed or decreased. The client will have thready, weak, and irregular pulses and hypotension. Respirations will be shallow and ineffective because of the profound weakness of the skeletal muscles of respiration. As a result, breath sounds will be diminished. The neurological and musculoskeletal systems are affected, and the client will experience lethargy, confusion, skeletal muscle weakness, paresthesias, and deep tendon hyporeflexia. Decreased motility of the gastrointestinal system occurs, and the client will have constipation, abdominal distension, and hypoactive to absent bowel sounds. Electrocardiogram changes will be noted and will include ST depression, shallow, flat, or inverted T waves, and a prominent U wave. How is hypokalemia treated? It is treated with oral or intravenous potassium. Oral potassium supplements can cause nausea and vomiting, and they should not be taken on an empty stomach. If the client complains of abdominal pain, distension, nausea, or vomiting, or if diarrhea or gastrointestinal bleeding occurs, the potassium supplement may need to be discontinued. Potassium also is available in a liquid form, but this form has an unpleasant taste and should be taken with juice or another liquid. Potassium can also be administered by the intravenous route. When it is prescribed via this route, the infusion needs to be controlled by an infusion device, and the nurse must monitor the client and the infusion closely. The top 10 pyramid points to remember about the administration of potassium include the following. 1. Assess renal function before administering potassium, because potassium is excreted via the kidneys. If renal function is inadequate, notify the physician before initiating the infusion. 2. Monitor intake and output during the infusion. If urine output is less than 30 milliliters per hour, or the client demonstrates other signs of renal impairment, stop the infusion and notify the physician. 3. Carefully monitor serum potassium levels and for signs of hyperkalemia during administration of the potassium. 4. Attach the client to a cardiac monitor and monitor the client closely for dysrhythmias. 5. Potassium is never given by IV push or by the intramuscular or subcutaneous route. 6. A dilution of no more than 1 milliequivalent of potassium to 10 milliliters of intravenous solution is recommended. 7. After adding potassium to an IV solution, rotate and invert the bag to ensure that the potassium is distributed evenly throughout the solution. 8. Ensure that the IV bag containing potassium is properly labeled. 9. The maximum recommended infusion rate is 5 to 10 milliequivalents per hour and should never exceed 20 milliequivalents per hour under any circumstances. 10. A potassium infusion can cause phlebitis. Therefore, the nurse should assess the IV site frequently for signs of phlebitis or infiltration. If either of these occurs, stop the infusion immediately. Finally, instruct clients at risk for hypokalemia about foods that are high in potassium content. Let's review a list of some foods that are high in potassium. Fruits high in potassium include oranges, bananas, strawberries, cantaloupes, avocados, tomatoes, and raisins. Vegetables high in potassium include carrots, potatoes, mushrooms, and spinach. Also, fish, pork, beef, and veal are high in potassium. Be sure to provide clients with a list of foods that are high in potassium content. This list will be helpful when planning an adequate daily intake of potassium. Finally, let's review hyperkalemia. The causes of hyperkalemia include excessive potassium intake, either orally or intravenously, conditions that cause potassium retention, such as potassium-sparing diuretics or renal failure, and conditions such as acidosis that cause the movement of potassium from the intracellular fluid to the extracellular fluid. Clients with hyperkalemia will exhibit a slow, weak, irregular heart rate, a low blood pressure, and profound weakness of the skeletal muscles leading to respiratory failure. Early signs include muscle twitches, cramps, and paresthesias. As the condition progresses, the client experiences late signs characterized by ascending flaccid paralysis in the arms and legs, then the trunk and head, and respiratory muscles become affected when the serum potassium level reaches a lethal level. The client will also experience increased gastrointestinal motility, hyperactive bowel sounds, and diarrhea. The electrocardiogram will show tall peaked T waves, flat P waves, widened QRS complexes, and prolonged PR intervals. What are the interventions for a client with hyperkalemia? If the client is receiving oral or intravenous potassium, stop these treatments immediately and notify the physician. If the client has an intravenous catheter, this catheter is kept patent because it might be needed to administer prescribed medications. Potassium-excreting diuretics may be prescribed if renal function is not impaired. If renal function is impaired, a medication known as sodium polystyrene sulfonate, also known as Kexolate, may be prescribed. This medication promotes gastrointestinal sodium absorption and potassium excretion. The intravenous administration of hypertonic glucose with regular insulin may also be a treatment measure and will promote the movement of excess potassium into the cells. Finally, dialysis may be necessary for the client who has a critically high potassium level and is not responding to other treatment. Instruct clients at risk for hyperkalemia about foods that are high in potassium and need to be avoided. Also, instruct clients to avoid salt substitutes or other potassium-containing substances. Now for a quick review and some self-check questions. Is a potassium level of 3.1 milliequivalents per liter indicative of hypokalemia or hyperkalemia? Correct, hypokalemia. A prominent U wave on an electrocardiogram would be noted in which potassium imbalance, hypokalemia or hyperkalemia? Correct, hypokalemia. A potassium-sparing diuretic could lead to which potassium imbalance, hypokalemia or hyperkalemia? Correct, hyperkalemia. Tall peaked T waves on an electrocardiogram would be noted in which potassium imbalance, hypokalemia or hyperkalemia? Correct, hyperkalemia. Hyperactive bowel sounds and diarrhea would be noted in which potassium imbalance, hypokalemia or hyperkalemia? Correct, hyperkalemia. Use of corticosteroids can cause which potassium imbalance, hypokalemia or hyperkalemia? Correct, hypokalemia. Intravenous potassium can be administered by direct IV push. True or false? Correct, definitely false. Bananas are high or low in potassium content. Correct, they are high in potassium content. Acidosis can cause which potassium imbalance? Hypokalemia or hyperkalemia? Correct, hyperkalemia. Sodium polystyrene sulfonate, known as K-exolate, may be prescribed to treat which potassium imbalance? Hypokalemia or hyperkalemia? Correct, hyperkalemia. Well done! This ends the Fluids and Electrolytes review. I encourage you to continue playing and listening to this audio review and to review Chapter 9 of the Saunders Comprehensive Review for the NCLEX examination. This chapter provides additional information about fluids and electrolytes in addition to practice questions. The CD accompanying the Saunders Comprehensive Review for the NCLEX examination will also provide these types of questions if you select Fundamental Skills, Fluids and Electrolytes, Acid-Base in the CD content area. I wish you the best of luck on your nursing exams and on the NCLEX.